Welcome to Stand Up for Doctors. I'm your host, Kim Downey. Thank you very much for joining us. I'd like to welcome Dr. David Morris. Thanks for joining us today, David.
Thanks for having me, Kim. It's great to talk.
Okay, it's great to have you. And I think we should probably say here is we were hoping for Geoffrey Roche to join us, and he seems to be having a little difficulty getting in with us. So he might pop in, and we've both agreed that that's okay. So we'll see how that goes. But by way of briefly introducing you, Dr. David Morris is joining us from Ireland. And he's a physician by training, CEO at Verity Barrington, executive healthcare leader, medical educator, and husband to Olivia Morris, who I've also had here on my YouTube channel. I had to give Olivia a shout out too. And that's episode 49 with Dr. Amy Jo Farrow. And Olivia and I have co-published a Kevin MD article, and we'll be recording a podcast with Kevin 2 weeks from today. And the two of you have the distinction of being my first husband and wife guest. So congratulations.
Thank you. I take that as a great first achievement. Brilliant.
Okay, terrific. Well, today the plan for us to talk about, which we still can, is, here he is. And Geoffrey Roche's tagline begins, "Son of a nurse leading with heart and purpose." And Geoffrey talks about leading organizations by embedding a culture of belonging, community, and purpose-driven transformation. So I'd like to introduce you to each other, David and Geoffrey, and to our audience. So welcome.
Thank you. Nice to see you, David. Thank you, Kim,
Good
for
to meet
having
you
us.
guys.
Okay, you're welcome. And today we'll be talking about what's going well with healthcare in Ireland and America, and what can we learn from each other, and how can we make things better for all of us. So I always start by asking you each to share what you'd most like our audience to know about you as we begin our conversation. And you can feel free to include hobbies, anything you want. So David, would you like to go first?
Yes, from my perspective, really, just to understand that I was a physician, worked as a physician, never wanted to be a doctor, but arrived there through physical therapy, same as you, Kim, and wanted to broaden my scope of what I did, and became a doctor and had a phenomenal purpose there, enjoyed doing it, enjoyed the work, loved the work, but really the system and the culture. And when my senior as a doctor, my boss, my direct boss, sat down and said to me after a couple of things that had happened at home, "You're going to have to decide between family and medicine. You can't have both." That was a very easy decision for me. I stopped that job. I went back to the doctor's office, typed up a resignation letter, and walked out of that job the same day. I wouldn't recommend everybody does that. Plugged along in medicine for a little while after that, but ultimately went away and tried to change the system from inside, but it was very difficult. So now I'm outside the system, working in an industry, running our own business, and trying to drive change in healthcare in an action-orientated way. So we've progressed for a long time trying to, with it's great, all of the people that are trying to raise awareness, they're trying to really change things with movements, and a lot of talking going on about what's happening in healthcare and what's bad and what's broken. We really need people to start coming forward with solutions and driving with action and changing the culture and actually being on the ground and doing it. So I try to support people doing that and try to drive that from outside the system, because sometimes it's so difficult to cause change in a system so big when you're stuck inside it.
Absolutely. And I had heard that story from both you and Olivia, and that should never be a choice that someone is asked to make between medicine and family. So I'm just so sorry that you had that experience. And I do love it, though, that you and Olivia have taken that and you're just working on solutions and action. I love those words, and I know that you're doing it and going to do it. And just us working around the world and sharing what's working, we're creating those ripples of change, as Dr. Todd
Absolutely.
speaks of. So
that's absolutely.
yeah, so thank you. Geoffrey, what would you like us to know about you?
Yeah, so from on the personal end, I've got three sons, age 9, 7, and almost 4, and so certainly that's a big focus for me. And I also say to a lot of people, I've had like a lifelong journey of trying to further understand how to be the most effective person I can be, and so self-care has become a big portion of me. And so my biggest hobby is running. That has really become, just my refuge every morning. where it's just kind of my time out wherever I may be. And I'm a big Peloton fan. And so just on the hobby end that. But I think to Dr. Morris's point, I've been privileged, obviously, as the son of a nurse to work in hospital administration, and then actually came into higher ed administration. And then also worked in global ed tech all around healthcare education. And obviously then now I'm in the med tech space. And so I've been fortunate to kind of be in the full spectrum of the healthcare ecosystem. But what always I've been reminded of is the power of relationships. There's nothing like a human-centered relationship. And I think that's what in many ways we've missed in healthcare as it's become larger. And it's what we need to get back to, is really the human-centered connection.
100%. That's what I'm all about. The power of relationships and connection and building a sense of community. I just love that. Thank you for sharing. And so, David, you and I have had a prior conversation, and we were speaking a little about you have a global perspective, and we talked a little about what's going well in Ireland and what we know what's going well in America and where could we learn from each other. So I was wondering if you'd like to start by sharing a bit about that, and then we'll have Geoffrey respond.
Yeah, of course. So I mean, I'm based in Ireland, but because we've been advocating and in this world and with the fantastic world of the internet and LinkedIn and everything, exposed to everything with people all over the world around what's working well and what's not. I suppose from the Irish perspective, we've a pretty good system overall. So the way our system is structured, it works relatively well. We've got a public-private hybrid, so we're not fully public, as much as the UK would be with their NHS. We've got a lot of, if somebody doesn't have money and they need care, or if they haven't got private insurance, they will always get the care they need. It may not be quite efficient enough. It's probably not the best experience in the world, the same as healthcare all over the world, as Geoffrey just alluded to there. Some of that human connection is gone. Some of the care has gone from healthcare. It's a very transactional. It's trying to drive volume for the region. Just don't have enough staff. It's not necessarily profit based here, but it's just that the systems are broken. There's a lot of middle bloat, and the clinicians are under pressure, and that's kind of what's happening here. The private system here works quite well, similar to the US. It's relatively profit driven, but I think experiences of staff and things in the private system here are quite good overall, and for patients as well. The US system, from everybody that we speak to, it seems like there's challenges the same as there are here. There's challenges in the US around healthcare. A huge amount of it really in the US revolves around, I suppose, the main purpose and the driver of what's driving healthcare now. And it seems to be money, profit, transactions, volume, and, throughput. And that's not healthcare. Healthcare cannot operate like that. It won't work like that. The clinicians lose their purpose, and being a doctor is hard enough. It's a really, really difficult job to do that. I've stood in an emergency department in the middle of the night, resuscitated a 3-year-old while her mother looked into my eyes and asked me not to let her baby die. I could do that. I was able to do that and live with that. And kind of, you had your purpose and you were doing what you needed to do. But when the system comes then on top of that and starts to pull away your purpose and starts to give you different priorities and starts to put extra pressure on you, and it's difficult then for you to manage your home life because your roster's so crazy, or it's difficult for you to build a connection with patients because you're being told to go faster, get through it. Why are you talking to that old lady? You've dealt with her antibiotics. Can you move on, please? You went into healthcare to care for people. And if you're ultimately being pushed further, faster, not being allowed to do what you wanted to do, that's what's going to break everybody's ability to manage. And that's a huge cause around the world, of driving more and more clinicians, doctors, nurses, everybody, administrators into a space where they're finding it difficult to cope. So I think that's a common thread. But I think sometimes what's working well, it's there's starting to be more awareness of it. There's a little bit of a push, from some administrators. So on the ground, people like you, Kim, my wife Olivia has done a phenomenal job for the past 10 years trying to advocate and get people more aware of this, and that awareness is rising. And then I think there's a little bit more action starting to come as well, and we see that in what we're doing and talking to hospital administrators, talking to people who actually can make these changes. That's starting to increase a little bit as well. So I think it's a positive that's coming through.
I love everything that you just said, and just one or two things is that you're right. Being a doctor is hard enough. Right, it's hard enough. And then when doctors are losing their sense of purpose precisely for the reasons that you listed, it just shouldn't be that way. And we all need to work together, to make a difference. So thank you for spotlighting that. Some of it is letting doctors know they're not alone and they're not the only ones thinking this way. And then other people to raise awareness, and to that we all need to do our part. So go ahead, Geoffrey. How would you like to respond to David?
Yeah, so it's interesting, right, David? I just am getting back from a week-long trip to the UK, where I had the opportunity to actually be part of a global convening of US leaders to learn and study for an entire week the power of the apprenticeship degree in healthcare. It's very interesting, right? Because to your point, I'm coming back from that feeling both energized, hopeful, but then also realistic, because the U.S., we have made it very, very hard to enter the healthcare profession. Here in the U.S., you have to choose between getting a job or getting a degree. In other parts of the world, including the UK and other parts of Europe, you could choose to get a job and earn your degree on the job. And I think that's really, really a critical thing, Kim, that we have got to move here in the US towards. And I'll tell you why I believe this going even before I went, but I further really understand it now, because I got the opportunity to meet individuals at both the NHS hospital, which was the John Ratcliffe Hospital in Oxford, as well as I got to actually meet some of my own colleagues at the Siemens MRI facility in Oxford. And, these are all students who are in their degrees while working on the job in various professions, but they're growing and they're further growing, to become nurses. And in some cases, they're going on to become doctors, but they're doing it through a stackable pathway on the job versus having to give up and go to college, have that student debt, and raise a family. They're doing it with the support of the employer, paying for everything on the educational end and supporting them on the professional end. And so I, obviously, as you know, Kim, I focus a lot on workforce, and we've got to move to that type of a model in the US. We cannot continue to have this type of a situation. The other thing that I'll say that I think is very, very interesting, and, David could speak to this more than I could, but it seems to me that we really in the US, from a healthcare perspective, really have a crisis in leadership. We have not done a great job of really supporting our middle management, both on succession planning, both in coaching, mentoring, and we really have a significant crisis. And we're really in trouble because the reality of it is the C-suite is retiring, and we have not really created, and frankly, so many of those C-suites have also ruined many leaders and many professionals as well. And so we really have an interesting dichotomy that's occurring. I'm not aware of it as being as bad in other parts of the world as it is in the US. But, David, you may have some other thoughts on that, but that's just some of the things that I would say. But for me, it's going to be really critical as a millennial, speaking as a millennial, when I think of the younger generations and beyond, we're going to have to shift these models in the US. We cannot continue the status quo, and we've got to attract more to the profession, because the number of people that want to serve in healthcare is the lowest it's ever been in the US ever. And there's good reasons why. We have not made the profession look like a place where you want to serve. When I started my career 16 years ago, I could never have thought of being anywhere but hospital administration. It was a phenomenal place to start. But I tell people all the time, my CEO was a nurse. We had a caring culture. We had a mentoring culture, and we all had truly an empowering culture. And so it was a very, very different place. And certainly it's a different healthcare system today, now compared to it was when I was there. So those are some of the thoughts.
I can come back to your piece there, Geoffrey, on the leadership issue. I think it's definitely it's a huge part. I think so. There's a couple of different things happening, and we see it as we're building our own business and as we're talking to leaders all over the world. I think there's definitely that piece where the C-suite has had this has a certain type of leadership instilled. That culture of medicine, or the culture of healthcare, has been pervasive, and it's almost like a hazing effect. And this is how we did it before. This is how we're going to do it again, and it's almost magnified through every generation in a way. And that doctor who said to me, "You've got to choose between medicine and family," I don't think that was his own thought. He didn't invent that. I don't necessarily blame him for that. He shouldn't have done it, but that's not his thought process. That was the thought process in the department, because that was the culture in the department. That was a thought process of doctors everywhere at times. And I've come across lots of surgeons and doctors and physicians, GPs, family doctors who would have potentially the same thought process because they feel like there's a level of self inflicted martyrdom which is required to be a doctor. And there's a piece that the leaders in healthcare systems they tend to compound that because it works in their interest. It keeps people working harder. It keeps them working longer. It means when it gets to time to go home and you've got 10 more patients to see, you don't just up and say, "Well, I don't know, I'm finished my job. Somebody else can deal with that." It keeps people there. It keeps people active to the point that they're no longer able to continue. So they'll use them up and they'll waste them. And there's a big piece of that has happened with the leadership. But I think as well as that, then probably is a gap for really strong, as you say, Geoffrey, when you started, your leaders were clinicians. And I don't think we're seeing as much of that come through now. And there's a couple of things that are happening there too. I think a lot of the clinicians, as they get more senior, as they become to the level where they'd be ready to go into leadership, they're actually leaving the profession. They're not staying in the profession and progressing into leadership roles. They're saying, "Well, maybe I can just go out and do some consulting. I'm going to go and start my own company. I'm just going to quit and walk away and find a totally different, I'm going to become a financier," because it's just been that hard for them to get through and they don't want to stay and they don't see themselves as being able to instill change if that's what they want to do. They just want to escape. And to your point around the attractiveness of medicine or anything else, it's the same over the world. I just read an article today where medical school applications in the UK have dropped 12% in a year.
Mm.
So it's happening everywhere. They've had junior doctor strikes, so the young doctors who are graduating aren't able to afford housing in the UK. They're making, when you put their overtime in, they're making the same as someone who works in McDonald's. It's not, it's not an attractive profession. And for that, then they have to deal with the stuff that I described earlier. They have to live that life as opposed to doing something else, which makes them more money and is a nicer life. And people aren't as attracted. That's just the way it is. So we're going to be in huge crisis if both of those things, if we can't keep leaders there, doctors, they have options, but it's good to keep them there and then bring more young, strong, good young people into the profession. We have to do that on both sides. And that's the only way that it manages to keep going.
Mm. Well, Geoffrey, I'm sure you'll have a lot to respond to what David just said. If you would like to do that, and if you'd both then like to speak to universal health care, right? That's, of course, the whole buzz thing in America, and some people feel strongly that we should have it. Some people feel strongly that we don't. I know that there's some people from Canada who end up coming to America for a hip replacement so they don't have to wait 2 years, so it's not necessarily ideal. There's nothing that's ideal, right? So I'm just wondering if you want to speak to that as a part of your response to David.
Yeah. So, I think to David's point, right? I mean, we have a lot of focus now in the US, increasing focus on how do we create more career connected programs at the middle and high school level to try and attract individuals into the healthcare profession, which I applaud. And certainly a lot of my work is around that too. The key, though, is to David's point, we're going to have to address the systemic issues in the system, because once you attract them, if they don't see a culture that they feel they can grow, they can thrive, they're going to leave. And we know the younger generations, that's what's happening. I mean, I look at it and it saddens me when I look at the amount of people that went for MHAs, went to become a nurse, went to become an EKG tech, went to become whatever the case may be. They get in and they leave. And instead of leaders sitting around and thinking, well, why did they leave? We're the part of the problem. They're immediately thinking it's, different. Oh, we're just going to do these engagement surveys. We're going to do these things. No, look at the facts. They're leaving because of you. Fix it. And this is where I have often said, this is where in the US, I often get criticized for this because some people say I'm a little crazy when I say this, but it's where the boards need to take ownership. Ultimately, the board of directors and trustees have a responsibility to hold the executive team and the CEOs accountable. And fiduciary responsibility is not just financial. Fiduciary is also people. You can't have a sustainable healthcare system if you don't have people. Thus, people equals finances, people equals quality, people equals patient safety. And so boards have to take ownership. And I say all the time, where are the boards? Where are they to care about these issues? And so That's some of the things that come to mind. Now, to the topic of universal healthcare, certainly I will give the caveat, I am not a policy expert on these issues, but I think look, there's definitely some elements that I think make a lot of sense. Certainly in the U.S., the piece that gives me great cause and concern with our current marketplace is, we're not really making great progress when it comes to advancing health equity. We sit at a time with healthcare disparities in rural, urban, suburban communities still terrible. When I think that maternal mortality is higher in the US compared to most other countries for Black and brown moms, it saddens me, but it also makes me extremely angry because that just should not be the case. But it also speaks to the systemic racism that exists in our healthcare system, and we have to acknowledge and we have to fix it. And I also think that there's obviously racism in our health insurance marketplace as well. And we see that. It's so difficult for individuals of different backgrounds to not just get access, but also to get approval on procedures. And so there's definitely some elements that do make me say, wow, imagine that type of a system. Now, to your point, Kim, I also get a bit of pause, and I'll give you this example. As I said, I do, have the opportunity to travel at times globally to other hospital systems and in countries that have different models. And I will say there is some element in the US, particularly around regulation, that I often wonder from a cleanliness, from a quality perspective, are we in a better place? So, for example, when I've been in some other countries' hospitals, I see things that I know would not be allowed in a US-based one because of Joint Commission and those types of things. And so in my mind, I just wonder, how could we create a model in the US that would truly fit our needs? I don't know if it's a full universal, again, not a policy expert there, but I do believe we've got to move to a model where whatever we do advances health equity. And I do recall during the Affordable Care Act, there were other models, not full universal, that would have gone farther to elevating and advancing those things. But obviously the health insurance marketplace had very powerful lobbyists and made it very difficult for those of us who cared about those issues to be successful. And so those are some of the thoughts that I have.
Well, thank you. And David, as you respond to Geoffrey, I will say the one thing that super stood out is in all that this is my, I don't know, 71st podcast, right? Since last November. And you're the first one, Geoffrey, to bring up boards, right? We talk about the C-suite, but you're the very first one to talk about boards being held accountable. And I fully agree. And I haven't really heard anybody talking about that. So David, go ahead, respond to anything that Geoffrey said, and also if you have any thoughts about boards, then their response.
Yeah, boards. Boards are great when they're effective. The boards need to be brave. The C-suite have a vested interest in making, and that's what happens. That's the culture, because the people who sit in the C-suite are the same leaders that have gone through the hazing, and they've come through all of those levels, and they now sit at the top. And when you cannot survive, when your clinicians, or as you say, your nurses, your ECG techs, your lab techs, if they're leaving in their droves, the board, the C-suite, the executives, this middle management, their direct line managers all say, they weren't cut out for it. They weren't strong enough to manage. So that's another one gone. You're a failure if you leave. You're the failure, not the system. Even if 20, 30, 40% of their employees are leaving, they're still the failures. They couldn't cut it. It's a tough business. They need to be stronger. And I think there's a bit where the C-suite need to, be held accountable, as you say, by the board, because the board that's the purpose of it. The C-suite have a vested interest in saying it's not their fault. Of course, they're going to say it's not their fault. The board needs to hold them accountable. So I agree with that wholeheartedly. And I think boards need to be braver and stronger and understand, as you say exactly, Geoffrey, that piece around, it's not just about bottom line. It's not just when the board is looking at it, they're not just there to sign off the annual accounts. They're not there to make sure that the big the capital investment is going in the right place. Is our human capital being looked after here? What's our human capital situation like? And is that working for us? And they need to hold the C-suite accountable. If the level of employee churn is beyond where it should be, they need to be asking the C-suite, why is that happening? And what are you doing to change it? So that's a key piece. On the point of universal healthcare, I think pros and cons. Having seen both sides, and in Ireland we have a nice blend. So as I say, we've got that middle ground. So I think about I think it's about 55% of the Irish population have private health insurance and can go and access private healthcare if they need to. But as well as that, we've got a whole public system that's funded by the government from taxpayers' money. And if you don't have private health insurance, you can go and get whatever you need to get dealt with, managed properly. It's relatively efficient, but there are challenges on both sides. I think from the perspective, and we see it in the NHS a little bit more pronounced even, the as you run a public system that's not profit driven, that's fully funded from public money, there can be a lot of administrative bloat. There can be a lot of issues that happen around that. Sometimes, it's just because it's not driven by, the right things necessarily. If it's being driven by outcomes and they're very evidence based, and the NICE in the UK, the National Institute for Clinical Excellence, are good at doing that. They try to make sure that the money is being spent in the right way, that they're getting the best outcomes. So if we're being outcomes driven, that's great. But a lot of the time, what happens in a public health system is it starts to be process driven as opposed to outcomes driven or profit driven. And when it's being process driven, it's a total, like they will throw money out the door for no reason. So if you're being outcomes driven, great. If you're being profit driven, not so good. But process driven is just money wasting. When you get to the kind of the fully private system and you talk about the US spends more per capita on healthcare than any country in the world. Do not have better outcomes than every country in the world. In fact, they have worse outcomes than many other countries that are, like Ireland and the likes of that. So that system does not work, where the money is not going in the right places. So it's great to spend $4 trillion a year on healthcare if your people are living longer, having great experiences, being managed proactively, and everything is working well. What's happening ultimately is, though, that's the $4 trillion is being funneled upwards and upwards and upwards and upwards into a bigger funnel at the top. And that's, growing year on year exponentially in different companies. And we don't need to go through them, but we know where it's all going. That system is not effective. So there's a piece where if that system was being managed more effectively and it wasn't so profit driven, that being held by outcomes, by profits, by bottom line, by all of that stuff is actually useful to a certain level. But when it just becomes overinflated and the emphasis is just on profit and private equity and making money for people who are so far removed from healthcare, they have no interest necessarily in outcomes at all. So that's the challenge, is finding that balance between the two. And I think it's a really difficult, as I say, same as Geoffrey, I'm not necessarily a policy expert on this. I have looked at both sides, I've examined it, I've worked in both sides, I've managed both sides, but I think it's just something that you have to find a balance. And I think the key part to it is back to culture and back to what's driving it from the top as well, is that we need to be focused on key parts of what healthcare is about. It should be proactive if we can do that. It should be humane and based on humanity and connection and care. And we're not just here to do 20 gastroscopes a day. We're not here to just manage loads and loads of procedures. Each one of those people is a person with a story that needs to be cared for, that needs to walk out the door feeling like they've had a care and they've been able to heal or get something done that makes them better. They're not just, it's not a widget factory, and we need to bring healthcare away from that.
Absolutely. I feel like we could talk like all day about these things. And Geoffrey, I'll give you an opportunity to respond to David. I do have one quick question going back to the boards is I've never been on a board, and I'll say that this is stereotyping, so I'd like you to speak to it, is sometimes you get the impression that the people on boards are like rich people that buy their seats, and they end up being yes men and yes women. So what do you think, how can we start to hold boards accountable? Like, what steps do you think we could take?
Yeah. So I think, to your point, Kim, right, that the reality of it is that if you look at U.S. healthcare system boards, majority not-for-profit boards, certainly there are those that are for-profit shareholders, but for those that are not-for-profit, less than 3% of those boards have a nurse on them. Most of them have a doctor, because they have the chief of staff of the medical staff that serves on there. But let's keep in mind that's an generally employed doctor. So, you're not necessarily getting an independent voice. And there's also the politics that can occur around those aspects as well. Generally, I would also go so far to say, generally, based on my own knowledge, those boards are generally also not representative of the community. They don't look like the community. They don't represent the entire patient base of the community. And so, to your point, not so much that they bought their seats, but certainly they're influential people that have a connection to the board because the board governs themselves. Therefore, the board appoints those that serve on the board. So there are remedies. One of which is certainly at a state legislature perspective, the state legislature could absolutely positively pass legislation that requires there be public participation in that process. Certainly could study these issues and certainly get a very strong sense of how to address that. There's definitely that element. I also believe there are federal government elements too that could be done, right? Because ultimately Medicare is a federal entity. For a Medicare pay, for a hospital that receives Medicare dollars, there could also be some elements from the federal government as well. We have to move to those things because the reality of it is that the board needs to look like the patients that are served. And so if you serve a population that has a higher Medicaid population, then there better be some Medicaid recipients on the board, because who's going to know how to serve those patients better than people that actually receive that? I will tell you that it's the same thing when it comes to, if you're a hospital system that studies maternal mortality, you should have somebody on your board who's dealt with those challenges. And if you at least don't have them on the board, for example, at my former healthcare system, our CEO created a patient family advisory council, and that council was so powerful because she made sure with our patient relations team that we had voices on that council that were telling us what we did wrong to help us do what's right. And she would tell everyone on our medical staff and our executive team, she'd make them attend, and every meeting she would say to them, you're quiet, you listen, they speak, and then we act. And it was very powerful because, to David's point, that clinician aspect, again, she was a nurse, but that aspect of who she was never left her. And so, those individuals that I know that have been on hospital boards, I think of, a lot of people know Jan Jones Schenck, who, created Western Governors University's nursing programs. Jan served as a trustee on a hospital board. That hospital had some of the top quality in the state of Utah. There's a reason. If you have somebody on that board who has that background, who's not afraid to challenge the executive team, who's not afraid to hold them accountable and say, boy, your employee engagement scores really, really suck. What are you going to do about it? And by the next month, I want to see results. And if there's not, we're going to have a different discussion. That's why boards are so important. And I will tell you, there's definitely remedies. And here's the thing. I think anybody that is in a community, if they feel they should serve on that board, just send a letter. Challenge the system. Send a letter to them and say, hey, I'm interested. In the US, there's a governance process. Every hospital system has a governing bylaws that runs how they do their boards. And ultimately, we've got to start to change it because these matters are of utmost importance. And I do believe until we change some of these boards, we're going to continue to have the same status quo because the boards are generally older. They're not representative of all the generations as well. And so, we've got to be mindful of that too.
Thank you. I really love that. And I think we're going to have to collaborate further. There's just too much, stuff to talk about. And as we wind down the last couple of minutes, David, would you like to share any top tips you have for your colleagues? And also just share a bit about Verity Barrington and how our listeners can get in touch with you.
Yeah, of course. I think the main thing from my perspective for our colleagues, really, when I look back and I think, when I was a doctor, when I went through that moment and I handed in my resignation, the next phrase out of that doctor's mouth was, you're going to regret this. There's nothing else for you out there. You're not going to manage a career anywhere else. This is going to be really hard for you as you move forward. That was what I was left with as I walked away. I just want to make it clear for everybody else that feels like they're stuck to medicine, huge amount of work, many, many years of study, and then an identity at that point that is your life. So you are an MD, you are a doctor, and that's what you are, and that's all that you stand for. And if you feel like you've got to walk away, that you're losing everything, you're not necessarily. Don't think that it's the only option for you. You'll always be a doctor. There are other things that you can do. You can go into industry. You can go and use your skills elsewhere. You can go away and be an airline pilot if you wish, and you haven't lost everything. You are not your identity as a doctor. So if you feel like that and you just cannot manage the system and it has been too much for you, then you're not alone. And there are other things that you can do, and you should talk to people and you should work through it. You have also got the solution. And going on to Verity Barrington, and what we do is we help clinicians, we help founders, we help entrepreneurs to build the solutions for healthcare. We looked at it. I've worked in many different companies. I've worked in startups. I've worked in big corporate. We've tried to instill change throughout the system, but really people find it very, very difficult to get going. And we take all of a big bunch of global experts. We give them access to these experts and we help them to build the companies and build the right solutions. We only support things that are going to help healthcare globally, and that's the biggest thing that we try and do. So we've got healthcare advice, we've got expert advice, we've got consulting, and we've now started to just recently we've launched some programs to help clinicians or entrepreneurs that are trying to build a healthcare business to understand that system. What do they need to do from the very beginning of the idea all the way to scaling that business and having an impact? Because so many people have good ideas, but to get an idea into the healthcare system and get it to work, to cause positive change, is full of bureaucracy, it's full of difficulty, money, and all sorts of things that clinicians and founders aren't really great at dealing with. So we help them to navigate that. And that's where we're trying to take action and help the people that have the ideas and the expertise to create that change, to come out and to go back in with their solution in a couple of years' time.
Well, thank you
That's
very
really what we
much.
try and do. They can get in touch with us. They can see what it is at veritybarrington.com or link up with me or Olivia on LinkedIn. I'm sure everyone has seen Olivia.
Awesome. So I want you both to send me any links that you want me to share in the show notes. So in the last 30 to 60 seconds, Geoffrey, if you have any advice for patients who wish to support their doctors, or let us know how our listeners can get in touch with you.
Yeah, happy to connect on LinkedIn. Great way to, great place to connect there. And Kim, thank you for all that you're doing too. I think, what David has reminded me in this conversation, right, is we have to all be in this work together. We have to really join as a community and really always keep people at the center of all this. And Kim, I applaud you for all the work that you're doing.
Thank you. Okay. Well, thank you very much. This was a fantastic conversation, and thanks again for being my guest today. And in closing, to move the needle in healthcare, we all need to raise our voices and we all need to care about each other. We already know that doctors need to care about patients. Patients need to care about doctors too. So stand up, doctors, and let's stand up for doctors.